Much. Our final panel today is here to talk about the evolving role of the physician organization in Michigan. And I will turn things over to my colleague, Director of Major Accounts and Emerging Solutions, Rick Wilkening.
All right, thank you. And yeah, I'm impressed with Shelley. There is still a nice group here. So we are in the home stretch. That's good to hear. And I think it's really nice that we've got this group up kind of winding up and bringing together a lot of the themes that we've heard over the past couple days. So it's my privilege to introduce our panelists. And these folks are the folks that are out there doing that daily grind to make the things happen that we've been hearing about as far as interoperability and sharing the data, reducing the burden on the provider community, and really helping the patients by using that information. So let me start off by introducing John Vismara. John is the president of Ingenium LLC and the vice president of information technology at United Physicians. As the president of Ingenium, John is responsible for the development of a physician-based health information exchange. Exchange facilitates clinical information sharing between physicians and other healthcare providers, provides electronic tools and applications at the point of care that enable physicians to effectively manage a defined patient population. In addition to his responsibilities with Ingenium and United Physicians, John is a member of the MyHIN board. And prior to joining United, John worked for St. John's Health System for 15 years in various roles, including hospital administration, facility services, management engineering. So he's been all over the hospital and the provider side. Next up will be Eva Matuszewski. She gave me that lesson before I came up. Thank you, Eva. So Eva's principal and founder of the Practice Transformation Institute. She's a Michigan-based healthcare veteran and champion of innovative primary care and chronic care initiatives, including the Community Care Travel Team, which received the Eagle Award from the Greater Detroit Area Health Council, or GDAC, in 2010. Eva is also the co-founder and CEO of Medical Network One, I'm so used to saying MedNet One, a health services organization established in 1981. Now serves more than 900 primary care, specialty care, and behavioral health specialists, in addition to offering patient-centered medical home and patient-centric programming and transformation services. Eva was named a champion of the new economy in 2011 by the Detroit Business Magazine for advancing the new model of primary care medicine in Southeast Michigan. In 2007, Crane's Detroit Business recognized Eva as an American dreamer in a feature highlighting successful foreign-born business leaders who built successful careers in Southeast Michigan. So thanks for joining us, Eva. And winding us up, Ed Worthington. Ed is the IT director for the Traverse City-based Northern Physician Organization, an organization of over 520 members, and their clinically integrated network, the Northern Michigan Health Network. Ed leads the Health Information Exchange, interoperability, population health information technology projects that have provided connectivity for independent and system-affiliated primary care, specialty, and inpatient providers. And yeah, that's a mouthful, and yes, I know Ed does all that. Prior to working at NPO, Ed worked with Munson Medical Center for more than 8 years in a variety of IT positions. And like everybody up here, Ed is an outstanding resource for folks to tap into across the state. So all these folks have not only been leading the charge in their own organizations, but have also been spending time trying to help other organizations learn how to use this information that we're passing around the state. And Ed specifically being from up north, and so for those of you who aren't from Michigan, Traverse City is right here, okay? That's how we do the state, Lower Peninsula. And all the folks that seem to be kind of above here are kind of those straight shooters that are just trying to get the job done. So I want to welcome all the panelists as John comes up to kick us off. Why don't you join me in welcoming them?
Thank you, Rick, and thank you again for sticking around. It's always a little bit nerve-wracking to see who will be here, but we do appreciate it very much. As I was looking at my slides earlier today and pulled this one up, I got a little bit worried that people might think I was going to tackle the philosophical question of what is poo. And I hope not to demonstrate what is poo with this presentation, but instead focus on physician organizations and really our role in HIE. But I thought I'd start, since I'm kicking this off, with what is a physician organization? Not everybody here is familiar with the Michigan landscape and how we're organized. A physician organization is a network of physicians. And primarily what we do is we contract with health plans for a variety of things, whether it's risk contracting to initiatives to services. And then based on those contracts, we work with our networks to execute them. And whether that's moving towards population health or providing services like care management, panel management, performance improvement kinds of activities, or services like technology, credentialing. Essentially what we're really tackling are those things that are either easier done at a network level or that really can't be done by the individual practices. It's just cost prohibitive or whatever for them to do it. So we tackle that more at a network level and combine our resources. A little bit about United Physicians specifically. It's a large physician organization located in Southeast Michigan, just north of Detroit area. And we are owned and led by physicians. That's very important. We don't have a hospital sponsor. We're completely independent from that perspective. We have a board of directors consisting of 21 physicians. And we have about 2,400, a little over that, members within the network. Multi-specialty, and it does include some hospital-employed physicians, but the vast majority are independent physicians. We have over 400,000 lives covered in our managed care contract, or our managed contracts, and they do run the spectrum of upside downside risk to really, quality incentive-based contracts and whatnot. And since we're such a large organization, we've had to actually break it into 6 geographic regions, mostly based on your affiliation with the local hospitals, because healthcare is delivered locally in the end. And what's happening in one region may not be very relevant at all in another region. So we've really found that the more effective way of dealing with that is to break the docs into regions. We have 113 employees, so we're a fairly significant organization, a lot bigger than most POs in the state. So since we're at the Michigan Connecting Michigan conference, we want to focus on HIE activities. So what is United Physicians looking for in HIE? Really, it's that movement of data, as you would expect. We have, our primary focus is to bring data in, to support our analytics and reporting, identify performance. We also take that data, pass it on to the health plans to support supplemental, quality reporting and increase our supplemental data to the plans. And then we also want to enable things like, transitions of care, ADTs, care summaries of discharge, that type of thing. And we've been doing this for quite a few years, probably over 10 years now, and we accidentally wandered into this health information exchange, and as a result, we actually created a subsidiary called Ingenium, as Rick mentioned earlier, to basically tackle those activities for the network. Importantly, since we've been doing this for so long, we've been working with MyHIN since its inception, one of the original groups participating in MyHIN. And what are we looking for in working with MyHIN? And really it's that 3 main things. The first being this convening and coordination activity, which is a very, very important component of what MyHIN does. It doesn't get a lot of attention, but it's critically important to the success of everything that we've been doing. Second thing is really that enablement of the exchange of information. That's the legal basis. I mean, without this, we really wouldn't be playing by the same rules and would have a very difficult time actually exchanging and sharing information. So that's that second layer that's super important. And then the third thing, we're not a big company. We are not a multi-billion-dollar company. And so we're a small company, and we need to make sure that we're maximizing our investment in technology. So we want to make sure we're focusing those investments in the right area. And by participating and working with this, we can position ourselves much better and know what everybody else is doing. There we go. Specifically, what we do with MyHIN is, we participate in a number of use cases, including the public health reporting, the ADT notification, MedRec. Participate in a number of pilots. Specifically, one of them is the Physician Payer Quality Collaborative. That's what I'm going to focus my conversation, and I think I'm going to let my colleagues handle some of the other areas. So I'm going to specifically focus on what we're doing with the PPQC initiative. And since I'm going to give a quick overview of what the initiative is, a little plug for tomorrow on one of the workshops. I think there's going to be a much deeper dive into this, the whole quality, measurement, development, and whatnot. So if you want to learn more, one of the workshops tomorrow will be diving much deeper into that. So I'm going to go do a quick, high-level overview of what PPQC is all about. So taking on that convening role, MyHIN and the Michigan State Medical Society convened this group, the group of payers as well as physicians, and created this collaboration. And it's really tackling quality, and specifically the supplemental data reporting to the payers, and bridging that gap between the physicians and the payers. And there's three main goals: common set of measures, common way of reporting that data, and a common way of receiving information back. To do that, you need a wide net of collaboration. And as you can see by the list of the payers here, as well as the physician organizations that are participating, there is a wide net. And we have really, really good participation in this initiative. And with this number of people, that's good and bad, because you have, if there's 25 different voices at the table here, we're going to have 25 different opinions. So bringing everybody together around clear common goals was critical to get this thing off the ground. And of course, where are we at today? What are we trying to solve? And what we're trying to deal with is that, as POs, we have to get data from the EMRs of our physician participants. We aggregate it, and then we have to create extracts to the health plans. And we have to create an individual extract for each plan that we participate with their measures, their data elements, their format, and we have to do this individually for each of them. And I'm sure from a payer perspective, they're thinking, well, I've got to get one of these feeds from every one of these POs, hope that it's in the right format, hope that it includes the right data elements, and try to see if we can use it. So it's complicated, difficult, time-consuming for all of us that are involved in it. So the first step is identifying what those core measures are. And this is the 27 core measures that have been identified. I think if you look at them, it's the usual cast of characters for the most part. And you'll recognize, I think, a lot of them. And then, of course, it's that simple thing of taking that spaghetti mix of data flow, flowing it through MyHIN, and landing at the payers, which is real easy to do in design and PowerPoint, but a much different challenge in reality. So I always love these slides. But at any rate, that is the basic intent, is to get it through that process. But when you think about all the steps that have to go through to get there, it's not only identifying what the measures are, but then you have to all agree on how we're going to send that data, all agree on what the data elements are that need to go into that report. You have to generate the extract. You have to validate the extract. You have to make sure that the plans have, we want to leverage the current MyHIN infrastructure, so the plans have to supply their patient lists. We have to incorporate that, validate that, and then we have to take the data coming from the physicians, match it against the matching algorithm, send it to the payers. Validation across each of those steps. And not just once, but from all of the POs, from all of the payers. So this is a big project and a big process. And I don't know, how long has this been going on? Well over a year. So seems longer, but no. It does. But at any rate, I do have, we've made great progress, and they've allowed me to make the big announcement here. Over the last year, we have been working very hard at working through all of those steps. And we've made significant progress through each of those. And this is the drum roll here, if I could do it. As of this week, we've actually passed one of the major milestones of having that physician data go through the matching algorithms, matching against the payer list, and as of this week, we're actually sending data now through this process to the health plans, which is a huge step, huge milestone, and quite frankly, once it goes through that validation process, we'll essentially be live. So I think that requires a little bit of recognition, so join me in noting that. So bringing it back to United Physicians, our particular spaghetti mess includes, we have to deal with over 40 different EMRs. We've got all of our physicians are on at least 40 different EMRs, probably more. And we're targeting over 200, roughly 240 different primary care practices initially. So that left-hand side of the slide is a lot more complex than this thing. We have to send it to 8, we're sending this data to 8 health plans, and the last count, we had over 47 measures we were dealing with and over 100 different goals for those measures. Each plan has a little bit different variance on them. So our particular spaghetti mess is for us very complex. So this program is really, really important to us because it's a really nice alignment between the program goals and what our goals are, of what we're trying to get out of HIE. And so that common set of measures and common methodologies really simplifies the process, reduces the confusion for the doctors, and most importantly, at least for our finance people, helps us really maximize and target our investment, which is hugely important for a small company, as you know. And as I said, it reduces the confusion of the doctors, and Dr. Simmer the other day mentioned that quality is largely an administrative project. And it is. I mean, it absolutely is. And the more we can take care of those administrative things, simplify it, reduce the confusion, that will help them with their workflows, get more consistency, target the right things, and we will see that improvement in quality. And even though we've already got these interfaces in place, this is still a better process because, as you know, measures change every year. There's a lot of maintenance that goes into it. And as things change, it really has a very high chance of breaking things along the way. And then finally, it really improves our confidence in our investment strategy and where we are. But the other thing that's not as, maybe not as apparent is that this is not a mature process. I mean, we've been doing this for a little while, but HIE standards, they're changing all the time. And, we talk about QRDAs, we talk about Medicare, Medicaid requirements, some of which have adopted, some of which haven't, the new requirements. EMR vendors are changing how they do things. Practices change EMR vendors. NCQA is changing the basis for how they're measuring quality. All of that stuff is it's a moving target. So for us, if we have to keep doing that across all 8 different plans with 40 different EMRs, it's really an untenable task. And our goal is to try to get 80% of our managed lives with interfaces and feeds to it right now, which we pretty much have. But what about that last 20%? It's very challenging for us. And working through this process, Mayan has created some new tools and some new processes that we can now take advantage of that'll help us get to that last 20%, help us continue to get data feeds from the first 80%, and really opens up that toolbox and gives us many more options for how we get this data and report it to the payers. And more importantly is it really helps us sharpen our focus. We will have to spend less time worrying about what format, what to include, not include, did we pass this or that audit or test, and really focus on quality improvement. Data quality, what's the data that we're getting from the practices? And we may have 20 practices on all scripts. Half of them we get really good results from, the other half we don't. Is it because they're bad doctors, they're not practicing well? Do they have bad workflows? Or are they just entering it in the wrong spot of the EMR? Those are the kinds of things that we really need to be tackling and dealing with, where we can put our energy and our staff effort, as well as looking at those practices that aren't doing as well, helping the practices with panel management, helping get those patients into the office, as well as care management. So we'll continue through this process. Excited to hear the data's now going to the payers. We'll continue to monitor and make sure that the verification is happening, the matching is going correctly. Really looking forward to getting consistent gap reports back from the payers. Right now we get all kinds of different reports. We'll be getting it electronic going forward, which will help us in two ways. One is, again, be able to create more consistent information for the physicians to help them in their workflows and help them be able to tackle what they have to do. But it also allows us to now leverage our systems to identify data quality issues and to be able to fix those things before the data even goes out the door. And then, of course, continue to focus on those data quality issues. And I guess I want to wrap my part of this by just saying that really, I hope it's come across, that this is a really, really, really good example of that convening role of MyHIN, bringing together a diverse group of people with common goals, common objectives, who really, really work quite well together, and remarkably came up with a plan and a strategy in a year to really simplify and improve how quality is being reported throughout the state. So, thank you.
Well, good afternoon, everyone. I'd like to go ahead and do some linking here today before I really move into the aspect of how we address ADTs, admission, discharges, and transfers. We've had some really great storytelling here today, and I'd like to add to those personal stories. Mary Ann Shelley and Dr. Ackerman really shared some great real-time stories, and I have a similar one, but I'd like to link mine to Dr. Shia's if he's still here. That would be the TEH component, the technology-enabled health coordination. So before Christmas this year, my almost 104-year-old dad fell ill, and he had lived with us for the last 7 years, requiring him to be transferred to the emergency room. So I got him into the car. I ran through 4 red lights. Thankfully, there weren't any police in the area. While he was being admitted, I went into the car to get my backpack because I knew he would not be coming home that day. So I took my little backpack in, he was getting settled, and I said, what the heck? I've been hearing about these patient pings and these ADT feeds that we keep getting. Let me go ahead and check and see if it's real. So I fired up my computer, my dad's sleeping. I went ahead and got into MedNet One's site because his primary care physician is a primary care physician in Medical Network One. And lo and behold, he's laying there, and I look and his name pops up, his demographics pop up, the fact that he's at Crittenton Hospital, his entire story. I go, this is really cool. I never thought that would happen like that. I kept hearing it could be real time, but it was real time. So several weeks later, as he was being moved from a post-acute care facility to our home, I was sitting in the parking lot, and he was in his transfer vehicle because he was in a wheelchair. And I said, this can't be possible. This cannot be happening. So I pulled up my computer, went ahead and just got my hotspot going, typed in the same information, and it showed that my dad was leaving Wellbridge, going home. Home care had been ordered, DME had been ordered, and his care team had been notified. How great is that? You know, 5 years ago, something like this would have never happened. So we need to acknowledge a couple of people. Blue Cross has done a phenomenal job in supporting these activities, because for those of you who remember the old Life cereal commercials, you know, Mikey, Mike, you'll eat anything? Well, there are some POs in the organization of the PICHA program that basically jump off the bridge every few months saying, okay, we'll be Mike, you will test it. So we, as our colleagues here at the table, have really gone ahead and jumped on this access of ADTs. So what did we used to do? For those of you in managed care, you would get a daily fax that would give you a whole summary. You took a look at the admission date, and it was 2 weeks ago. You called the patient, and then you found out that they had now been put in a different facility. No consistency in the information whatsoever. You never knew what to expect. Significant delays. I had a patient in the hospital for 360 days. I didn't know until the day he was discharged, like almost a year later. DME, you never really heard about that on those census reports. God forbid home health care, and you never heard anything whatsoever about skilled nursing facilities. So this is where we are right now. We have really moved from best practices, because I'm getting a little tired of hearing everyone talking about, well, this is best practice, this is best practice. Show me common practice. So for those of you that are now really involved with a lot of these use cases and activities, you should be moving beyond best practice into common practice. So we at Medical Network One have been using an ADT feed for almost 3 years now, and guess what? We've moved beyond best practice into common practice. So as my care managers begin to pull up whenever their work schedule allows them to do this, that daily ADT feed in the morning, in the afternoon, whenever they do it, all of the demographics pop up. They know what the insurance carrier is that's attached to that patient. They know the PO affiliation. They know PCP affiliation. They know exactly where that patient is and where they're going. I'm using Dr. Simmer's quote from a few years ago, because this is probably the most important facet of those ADT feeds. It's a service, it's a very important piece of improving patient care, because it gives not only primary care physicians and their care teams, it gives everyone a single access point to timely information. How great is it that our entire care team at Medical Network One, that's either a floating team because we have traveling teams or embedded teams, can actually go ahead and access this information. And the beauty of it is they can work on it, they can act on it. So what if you know that a patient's in the hospital? What's the next move? What are you going to go ahead and do with them when they're discharged? Who's going to do that med rec? We're fortunate because we have a pharmacist that handles that component for us. So way back when my team decided to do some research on what's this ADT stuff. So for those of you who don't know, ADT is truly a trademark. And I'm waiting for ADT to call us one day and say, stop using it, because we're a corporation that does residential and small business electronic security. Well, just think, we're actually doing the same thing. But we're not doing residential and small business electronic security. We're actually doing healthcare security. So the two actually mimic each other. And then I just threw the other ones in. It's average daily traffic count. It could be like an associate's degree for transfer. And then all of a sudden we sat down and said, what in God's name is this advanced Dvorak technique? Can someone tell us? Now we know what ADTs are. They fall into those really important categories in real life, real everyday life. But what were the challenges? Has anyone ever seen, and I bet you have, what those HL7 records look like when they come over? Okay, so what do we want? So the first time we saw that, we took a look at what each hospital was doing. Great, you had that HL7 standard, but you identified gender differently. There were different things that would be identified differently. There was no normalization going back 3 years. Now there is. We know that it's happening the way it should be happening. So in 2014, we actually went ahead and sat with our friends at MyHIN and our friends at Blue Cross and Blue Shield. And at that point in time, we submitted our ACRES file. We really began moving into the area of finding out how to make this happen in all of our practices. Now, mind you, we're in 5 counties, from St. Clair County around Port Huron all the way down to Lucas County, Ohio. So how do you take all of these folks and get them on the same page? It's known as education. We now know that a healthcare provider can go ahead and get this information, but doctors don't do this. You got to have a care team. And unless you train a team, and we've been talking about this all day today, you have to have people that support the tool. If you don't have the people to support the tool, great, you've got a tool. That's all you have. But once you've gone ahead and effectively trained your folks, you can go ahead and really make those tools function extremely well. But it's not one-time training, it's ongoing training. You cannot go ahead and assume that things are just going to happen. So our biggest challenges continue to be the same that were in place a few years ago. However, we've learned to work around those challenges. I guess you get a little tired of people complaining and saying, we don't have this, we don't have that, you're not doing this right. Be a positive thinker, be innovative, Be willing to go ahead and take that step forward. So our biggest challenges continue to be revising workflows. You've been to one practice, you've heard this time and time again. You've seen one practice. So we keep sending our folks out. Mark, who sits back there, who oversees the overall activities of our care teams and a lot of other things, he ensures that there is actual training. Show me, the two famous words, show me how you're doing it, and then tell me what you're doing with it. It's not enough to go ahead and if somebody pulled a report out, show me what you're doing with it. What's that feedback loop? How are you closing it? And again, training alert recipients on appropriate routing. This looks pretty vague. It's a patient roster that we're able to pull up for all of our patients that are either in the emergency room, that are in home care services, that are receiving any type of DME, and that are inpatients. And this is something that we rely on. The screenshots aren't very good, and I apologize for that. And you also know where the patient is. You can identify your frequent flyers. And it's not that you're waiting 2 weeks. You sit down in the morning if you want to come in, and your care manager comes in and says, you know what, I want to take a look at all the patients that were in the emergency room in the last 24 hours. She can pull it up, he can pull it up and take a look at it. And this is now beautifully linked with maps so that we can have our care managers review that information, and if the patient is a frequent flyer in the emergency room, we can now act on it. And I keep stressing the fact this is not a physician tool. This is a care team tool. Everybody should be engaged in this. And some of our physicians rely on this. They look at it themselves, but they make sure that the care team is truly involved in those activities. So on high admission, for example, who's that high utilizer? What are you going to do with them? How are you going to educate them? So in our organization, many of our high utilizers are drug seekers or individuals that truly have social determinant issues. Our pharmacist does a great job in doing that outreach. Two of the areas in this sphere that we really rely on are our behavior health folks and our clinical pharmacists. So I will just go ahead and also tell you that we're actively engaged in CCDs and doing MedRec, and that's something that my colleague from up north will go ahead and touch on. The CCD views are great because our care managers are acting on them. It's not just that they appear, but they're actually actionable. And what we're finding is we have to now reduce the amount of frequency or the frequency of alerts, because we too suffer from alert problems. I mean, you want to go ahead and put it away. You don't want to keep looking at it. So every clinician decides what they're doing. We have coverage on weekends to make sure that on Monday when those clinicians come in, they don't have 2,000 messages that they're dealing with. So this is consistent. 7 days a week, there is someone who is looking at this. And lastly, if you're interested in taking a look at a live version of this, I can meet you out there and show you exactly how these alerts look, and I can walk you through the process of what an ADT feed should look like and how you can engage in the activities that will really provide better care at the right time for the right reasons for your patient population. Thank you.
Okay, so I'm going to be talking about the medication reconciliation use case, and then just to provide some more brief background on our organization, Northern Physicians Organization. We have 500 plus members, as Rick said, and just like what John's first slide or second slide on what a PO is and what a physician organization is or does, you know, we provide all those services to physicians primarily in the Manistee area, Traverse City, and Petoskey, so northwestern Michigan. And we have over a dozen different EMRs, different hosting environments. So some physicians host it, have a server in a closet in their office. Some are hosted by a local health system. Some are hosted by their EMR vendor. So we have a large, heterogeneous environment. And because of the services we have to provide and the contracts that we're maintaining for our physicians, having and affecting, meaningful, actionable information exchange is important, and additionally doing so, you know, on a wide, you know, for our whole geography, and in a way that's affordable so that we have funds available to work on other more direct care-oriented, you know, cases or processes. We didn't want to, you know, we want to make sure when we're engaging in different IT projects, we don't, you know, spend all of our budget on that, because there are a lot of other things that go into, you know, affecting healthcare and the triple aim. So just to provide some background on what the medication reconciliation use case is, it's really the next step in the ADTs that I was talking about. It's a service that uses MyHand's existing infrastructure, you know, ACRES, the health provider directory, and the legal sharing framework that exists in the state to send standard, you know, continuity care documents to the care team for a patient whenever a patient's discharged. So I think, Rick, at this time, is it 60 or 70% of the beds in the state or something? Yeah, so about 60 to 70% of the hospital beds in the state are sending these documents when a patient's discharged, and they're sending them usually within a few hours, or, you know, the latest we've seen them in our organization is the next morning. And they're coming, you know, they come in right into the organization, and based on, you know, how their providers are set up in the health provider directory, they're routed to the provider under with that mechanism. So the flow, you know, when a patient's discharged, the CCD is sent to MyHand, and then MyHand uses ACRES, like I said, in the health provider directory to figure out how to route it to the different organizations for that patient, so that the entire care team gets that same consistent document. Oh, forgot this one is animated here. You know, and the benefit is that, you know, whereas an ADT message is useful, and we've had a lot of use of it in our organization, you know, it doesn't provide a whole lot of clinical information. A MedRec CCD provides, you know, a picture of the medications, allergies, the problem lists that were active, you know, at the time of that discharge event. So that provides the care team with that picture, so that, you know, instead of getting an ADT and then having to maybe go into a different system or making a phone call, you know, without that information, they now are informed when they begin their reach out process for the patient. Additionally, you know, a benefit for this is that it, you know, it's in production right now. It's flowing, you know, I said, from a large number of these ERs and inpatients, and it's covering ERs, inpatient, and observations at a minimum. So you're not just getting patients that were, you know, officially made inpatient and then discharged. You're getting those 3 different patient classifications. And what we've seen, I think, in the different groups that have been working on this use case and have implemented, is that there's usually 2 different ways that a physician organization or a group will implement receiving and processing these documents. Usually they'll either, you know, if they have an existing portal or they have like a portal product, they will receive them into that portal, and it'll go into that existing process that the patients have, or the providers and practices have for viewing patient information. The other process or other way is directly into an EMR using direct trust most of the time. They both have their benefits. If there's already existing portal process or portal tool that's used and it has a high level of adoption, you know, obviously it makes sense just to continue using that. What we found at NPO is that sending it directly to the EMR via direct trust, it helps build on some of the additional, you know, existing interoperability efforts, and it encourages people to use it because they don't have to go to a separate tool. They can go right into their EMR. A lot of times the EMRs already, you know, receive it, you know, send it in just like a referral. So it's something that, you know, it's put right in front of them. They don't really need to have any additional processes in place to begin viewing them. And what we've seen in our organization is that, you know, practices, you know, use them to reach out and start, you know, a transitional care process with more information than they did with the ADT. The ADT helped them, you know, do that proactively before, but now with the MedRec, they can, you know, do that with additional information, and they can, you know, go through and talk through the medication list with the patient on the phone, or if the practice has a care manager assigned to them or they have their own care manager, they can use it to better monitor complex patients. Additionally, they come a lot sooner than fax documents. So I know most of the time, a patient goes to the hospital, they're discharged, especially if it's a local hospital for that provider, they'll get a document, usually a couple days later via fax, or, it'll be amended a few times. It's not, a really timely process just because of the process itself. These, the CCDAs or the MedRecs come, within a few hours, like I said, or to the next morning, so that, they can really begin that process quickly and, capture more transitional care revenue. So I'm going to show you here and then the next slide just how it looks in an EMR. This is actually a next-gen practice of ours. When they imported the CCDA in its entirety, or the MedRec, it just shows up in a list in the patient's documents, and they can scroll down a little bit and have a table of contents that's hyperlinked and click through and see different parts of the MedRec, the problem list, the allergies. If some labs were sent, they can see those, et cetera. They can also go through an import wizard right from their referral screen, so they receive it into their provider's inbox as if they were receiving a referral from a specialist. And there are different tabs there, problem list, procedures, et cetera. And anything that's available in that CCDA from the hospital, they can click through and decide what they want to import. So they can reconcile the meds, or they can leave the meds. They can maybe keep some problems that they want to add to their problem list, leave some out, et cetera. And then they have a summary at the bottom so they can see exactly what they're doing. Click OK, and then it reconciles the chart with that CCDA. For some of the benefits, as a statewide service, providers and practices, they don't need to develop different processes for different hospitals. So if you're in an area where patients go to different facilities, or patients just go to different facilities. In our case, we have a lot of patients that only spend part of the year in our region, or they spend a significant period of time down in the southeastern part of the state, and they just come up part of the year, but they end up assigned to us because that's where their primary care provider is. We don't have to develop processes to try to get records from different hospitals. We can receive everything through one interface, one process, and it makes the practices more efficient, and it helps us make sure that we're not losing or missing information that we otherwise should have to better manage our population. And for hospitals, it helps them because they only have to do it once. If they have, all hospitals have a larger number of providers that they're working with in different areas. They don't have to try to figure out how to develop different interfaces to accommodate different EMRs or different processes or tools that providers are using. They can just send everything to MyHIN, and then MyHIN takes care of the attribution and sends it right to the provider. Like I said, we use Direct Trust to send them. So we enroll our practices. We work with their EMR vendor to enroll them in Direct Trust, however that EMR vendor has it set up. Most of the time, that means they assign a Direct Trust account to every provider. So once we get that set up, it's a very affordable interface or tool to use to send data and receive data. So we get that set up. We get it. We have the providers start using it. We figure out how to make sure that staff have access to it so that it's not falling on the providers. So one thing that we do is we make sure that when a direct account is set up, there's a staff member that has, essentially proxy access to that provider's inbox, so they can, view the check a couple times a day, get the documents in and process them. The other thing that was a benefit to using Direct Trust for us is that because of meaningful use, some of our providers already had it. And in, any of the providers for any physician organization, they probably have a good number of providers that have Direct Trust accounts. Maybe they set up for meaningful use, never used it, or just had it set up and they didn't know about it. So it's something they can reuse something that already exists, so they don't have to expend funds on additional interfaces. And for us, it allowed us to concentrate on the process at the practice level rather than trying to accommodate a new tool or a longitudinal record or any kind of external tool into a practice's workflow. Rather, we could say, we can get the data right in front of them in the tool that they're sitting in all day and figure out how then to use the data to drive better processes in the practice. And then for us, we found the benefits are that, promotes PCMH, the patient-centered medical home model, by keeping primary care providers informed about transitions of care. And I'm kind of a little cautious on this one, then reducing manual entry, because there are some issues with EMR vendors. Of course, that should be assumed, I think, for everyone in this room. But, that the importing, all of them should or supposed to, they can import, but the mileage varies with different EMR vendors. But where the importing does work, it works really well, and it reduces errors, and especially in entering and changing medications when a medication might be slightly modified during a hospital stay. And like I said, it helps the hospitals accommodate their heterogeneous population, ambulatory population that they're working with. And we found one big benefit our providers is they liked receiving the documents earlier, and when they got things like ER labs and discharge instructions in there, that helped them really follow up with the patient to get them in the office sooner, rather than having to wait a few extra days. And that said, there's still, we're still very much kind of I would say, in the implementation phase of it, in that, the technology is working great. Direct's easy to set up. The interface with MyHIN is working great. The existing infrastructure MyHIN has is working great. But what I say we're still implementing is that, 90+% of the work going forward really is changing practice process. That now we're putting all of this data in front of them. We're expecting them to use it to, increase transitional care visits, be more effective in their care management. And so it's working with, this data to make sure that it's actionable, that it's used, that they can make it part of their workflow rather than just something, some additional button they click because they feel like they want to just, go through the process there. And then, of course, like I mentioned earlier, EMRs are different in how they handle direct and in how well they've implemented the importing of CCDAs directly. And then I wanted to end with some of the existing work that's going on now that some of this core infrastructure is done. Blue Cross has sponsored some different cohorts of physician organizations throughout the state that have been working together, especially on things like process and conformance with MyHIN, so that the CCDAs that we get are more standardized, so that they're easier to process by practices. They're more predictable in their formatting. Everything lines up more in context with what it's supposed to be, so that, the medications that were administered are showing up in the right spot, the medications that were, still active at discharge are showing up at the right spot, et cetera. And like I said, they've been working with MyHIN and the different physician organizations on really making sure that the parts that need to be in there to affect process change of the practices are in there. And then I think MyHIN's continuing to work with additional facilities, I think, to onboard them, right? So that we have a larger footprint in the state that are sending these. And I know that there's going to be testing started with sending some specialty practices or ambulatory practices, sending CCDAs to MyHIN, so that those documents, when a patient, has an encounter with a provider, that's outpatient rather than an ER, OBS, or inpatient, is sent through the statewide service and gets to the care team. So it's not just hospital data, it's all that other data that happens that's involved with patient care. Thank you.
All right, thank you. We did have some time left for questions. So I know folks have the mics and there's some hands going up, but why don't I lead off one just to get the panelists' opinion on. So for the use cases you talked through, what, from your perspectives, were the biggest challenges you encountered from the physicians? I heard a lot about the process on the practice side, but wanted to see if there were other challenges that you saw when you were trying to roll this out in your organization.
Everyone's looking to the right.
There's no one else to look at then, right?
So some of the biggest challenges that we actually encountered, you've probably heard the term flavor of the month. They were fearful that when we came on board and started showing them a tool like this, that it would suddenly disappear. So they needed to know that this was here to stay, and that they would be able to embrace that tool and eventually have that information going directly into their EHR. So just the steps that would go into ensuring that it became a part of the permanent record, that's where we found our biggest challenge.
For us, I think it was getting to that, now that they're sending them, we're sending them to practices, my hand's sending them to practices, they're getting this data, the CCDA on discharge, or CCDAs on discharge. It was trying to figure out how to live with the variability in how different products or EMRs handled the data, and still trying to work towards what you talked about in yours, of that common process, or that standardized workflow that's optimal.
They took what I was going to say, so man, all right. No, the only other thing I'd add would be that it certainly, building on the two themes of, having each practice having a different workflow, a different product, a different platform, and the flavor of the month, it certainly helped when you're able to consolidate around a common set of goals, a common way of doing things that's consistently across the spectrum, whether it's all the hospitals doing things the same way, all the health plans doing the same ways. Those are the initiatives that really have taken off and been much, and of course the incentives from the payers, Blue Cross in particular, have certainly helped. But when you have that consistency, that really has helped help initiatives take root and be much more successful than the ones that we've been trying on our own.
And I'd just like to add one more thing. For those of you that are really working on MACRA, and you're looking at what MIPS and APM has identified in this area, you're further ahead already if you have the MedRec and you've got that CCD and you've got an ADT feed, because that's exactly what CMS is looking at. Do you have that? What's your real time look like? And those are questions that are going to be asked in the future.
Thanks. And one quick clarification, we're actually up to 80% of the discharges are now sending the MedRec information as well. So, all right, I know there are some questions out there.
Yeah, quick question. Reed with Medical Advantage Group. You said, first of all, thank you for consolidating the payer feeds. That didn't seem like logical work a few years ago when we started it. So thank you for that. But you said you're sending 27 HEDIS measures to all those different payers. Are you including all 57 service codes if they're approved for Blue Cross Blue Shield? And are you including the 100+ data points that Priority Health accepts as well? Perfect.
Yes.
Thank you.
I'm looking at the guy behind you who actually knows more of the details, and he isn't waving his hands no, so yes.
One question. And you talked about some of the variability and consistency with the CCDA and the different EMR products. What are some of the challenges you've encountered with variability with the CCD itself and how the different EMRs actually produce it? Yes, it's supposed to be standardized. It is far from it, though, and actually how the EMRs, different EMR vendors actually comprise it, and then the complexity expounds with the different workflows that the providers had. So just asking, can you speak to some of the difficulties that you've had with that and implementing it, and how we can all work together to mitigate some of those?
I think, one of the big things we've seen is that the EMR vendors don't, and this is probably the most critical from a safety and from a safety perspective and a clinical perspective, is that they don't always handle or put the medications kind of in the right spot, or provide all of the information on the medications that occurred during the hospital stay. And I think as far as kind of working with it, I know that since it's been a collective challenge, that's being handled, worked on with the health systems to see if there's anything that they can change on their end, or if there's pressure they can put on their vendors that are producing them to make sure they're produced in a logical manner, not just one that minimally meets the specifications. I think on the ambulatory side, I think what we're for an ambulatory CCDA, it's really figuring out how to get them created in an automated way. That's been the biggest challenge. Not all ambulatory EMR vendors. Sorry. Oh, thanks. Not all ambulatory EMR vendors have easy or affordable ways to automatically generate a CCDA and send it to a statewide service.
But I need to add to this, there was a work group that was developed, again, at the Blues, and we would meet quite frequently to identify exactly what it was that we wanted on that CCDA, because if not, you would be getting information that in most instances would be useless. So we had a really great core of folks from the health systems. We had pharmacists, we had representatives of the POs that made that decision, so it made it a lot easier.
Right. I think the good thing is that those groups still continue to meet and continue to kind of share their findings and work on refining the process.
The only thing I'll add is that it also points out the importance of that validation process. You know, what Eva talked about relative to the ADTs, you know, it's a much more complex process validating CCDs and making sure all the data that's in there. But that's a key component to any of these initiatives that we've been doing.
Hi, Tom Simmer from Blue Cross, and I want to thank all of you for what I consider the most encouraging and inspiring panel or presentation at this otherwise very encouraging and inspiring conference. Congratulations, because you have really taken all this work and brought it essentially to the bedside by bringing it into the EMR. And I actually I did not know that we had progressed to that level, and it's just great to see your work. My question really relates to, we saw yesterday a very, very long scroll down of a CCD, and yet it seems like you've been able to compartmentalize it and allow them to find the information easily by clicking on a descriptive point. Is that something that's working well, number one? And number two, given the variation in the EMRs, are you communicating that to anyone who can guide physicians related to the strengths and weaknesses of the various EMRs to sort of guide choice and so forth?
To kind of tackle both parts. One, like I said, even where an EMR can't import, you know, discretely all of a CCDA or a CCDA at all, I think every CCDA usually is formatted with the table of contents that they can at least click through and get to the different sections easily. So that makes, like what you said, is can be a really long document, easier to navigate. The different working groups or cohorts that Blue Cross has and with MDC have been working together to collect information with different vendors and started to even discuss or get contacts with different vendors on engaging them on either, figuring out how to work with them with these or how to improve them. I don't know if there's been any kind of action taken on really, essentially reaching out or, calling out, vendors that work really well with CCDAs and, shaming the ones that don't. But, right now I think the emphasis really is on getting them to at least do what they've claimed that they were supposed to be doing for a while now. Which if they were, then, all of them should be at least able to take a document, import it easily, and, read some key parts out of it and make a provider's life easier. But that's not, always what we're finding.
So I know we're addressing that we're actually connecting Michigan for healthcare, but we still have a very large number of single and dual practices that are in paper charts. So for those of you who have those relationships, this is a great way in which to influence those practices, to begin thinking about moving into an EHR. And since the ADT feed that we receive is a cloud-based product, we can show them how easily they can access it, but then we can also tell them, if you had this, you'd be able to move to the next level, and you'd be able to really use this tool more effectively. So again, it's not just about what we have, but it's about using this as an influential package.
One more quick question, please.
Hi, I'm Jenny Lekich from the Physician Alliance, and I have a question with regards to the MedRec. We currently are looking into exploring the medication reconciliation, and what we're finding is that a lot of times when we're receiving prescriptions, or maybe not prescriptions, but medications, they're not being correctly marked as inactive. Maybe it's an antibiotic, and like it was taken for 10 days, and it stays in the patient's chart, and it actually will then come in. So it's kind of like garbage in. And I'm just wondering, what do you have in place today for MedRec that allows us to know that this truly is what the patient received in the hospital versus what they could have received from the ambulatory product that's integrated?
Okay, so one thing we realize about the current feed that we get, the ADT feed with that CCDA, it's known as garbage in and garbage out. So if the hospitals don't have a mechanism to really evaluate what's starting at their end, we have no control as to what we get. So we're hopeful as we begin to work more closely with the health systems that we're going to be able to rely on their own auditing mechanism to make sure that what we get is appropriate. And that's a great question because we really struggle with that at our level.
I think you also point out another thing where as we're getting this data and getting it flowing, I mean, it's all great and it's a lot more than what we've had in the past, but we do run into the danger of information overload, too much noise, and having the reverse effect of physicians ignoring it because of that. So this process and the ongoing validation and commitment of working with the hospitals and the participants is critical to the success in making sure that we don't get off the rails accidentally.
I'd just like to say one last point on that. I think the people have talked about the Blues incentives from the physician group perspective, but I think the Blues incentives and others, the other Medicaid health plans will now be starting their incentive programs this year, moving into next year, towards the hospitals in their value-based contracts there, and tying those to conformance. And Eva spoke to the fact that now, at the beginning there were probably 100 feeds coming at you for just ADT, but that was over the course of a year, and the conformance requirement in the incentives helped MyHIN be able to define what the report cards looked like, hand them over to the folks that are providing the incentives, and then make sure that we're on that path to normalization of the data and really reduce that variability and increase the validity of the information. So.
Can I just add one thing? So I don't know how many payers are in the audience, but I do have an appeal to all of you. As we work with our care teams and our care managers, and all of us are driving to population-based medicine, I would appeal to you to make sure that you find the time to reimburse those care managers that are doing your discharge summaries, that are actually working that MedRec, that are ensuring that your patients are not readmitted to a hospital or to a SNF, because many of you are not acknowledging the work that all of us are doing in that care management sphere. And what's happening is you're getting the benefit of all of our work and we're not being compensated for it. So when you're sitting out there, no matter what payer you're at or what payer you are, please take that into consideration. We are population-based organizations, and you rely on us more than you actually think you do because of that care management structure that we have.
All right. Well, once again, thank you to our panel.